I would say कि epidemic which is coming at least in NCR or
Still, we are fighting with COVID and understanding it simultaneously. A new post-COVID threat has surfaced: black fungus, mucormycosis. We know little about it, but if we have to emerge as a warrior, we need to know everything about it. So today we have invited Dr. Rakesh Gupta, a senior eye surgeon, director of Shreya Eye Centre, to throw some light on mucormycosis. Dr. R.C. Shridhar, a very senior family physician, will be putting up the questions. So it's over to you, Dr. Shridhar.
सर, ये आजकल जो कोविड के पेशेंट आते हैं, इसमें कुछ फंगल इन्फेक्शन हो जाती है आई में, नोज में, एंड इट मे गो अप टू लंग. इसके बारे में आप क्या कह सकते हैं?
हाँ, देखिए ये सर, इससे मैं बहुत रिसेंटली एक बड़ी नई सिचुएशन डेवलप हो गई है, राइनो ऑर्बिटल सेरिब्रल म्यूकोरमाइकोसिस, जो कि ब्लैक फंगस इन्फेक्शन, जो आप पब्लिक नाम से सब परिचित हो चुकी है पूरी इस समय. ये एक बहुत सीरियस एक कॉम्प्लिकेशन आई है जो उन पेशेंट्स में जो कोविड से रिकवर होके आ रहे हैं. जो पेशेंट्स खासकर जो एडमिट हुए हैं, जिनको साइटोकाइन स्टॉर्म आया है, जिनको ऑक्सीजन चढ़ी है, स्टीरॉइड्स दिए गए हैं और उनका मेटाबॉलिक इम्बैलेंस काफी रहा है, उन पेशेंट्स में ये बहुत सीरियस कंडीशन डेवलप हो रही है. और म्यूकोरमाइकोसिस, आई थिंक बहुत लोग नहीं जानते होंगे, एक बहुत सीरियस फंगल इन्फेक्शन है. फैटेलिटी ऑलमोस्ट 60% से ज्यादा है अगर वो टाइम पर डिटेक्ट और कंट्रोल नहीं होती है. तो मैं बताना चाहूंगा, कोविड की मोर्टेलिटी 1 से 2% के बीच में आती है, लेकिन जो आरओसीएम यानी कि जो म्यूकोरमाइकोसिस है, अगर ये एक्सटेंड करती है तो इसकी फैटेलिटी 60% से ज्यादा है.
एक्चुअली व्हिच ऑर्गन इट अफेक्ट्स?
इट स्टार्ट्स फ्रॉम नेजल म्यूकोसा, बिकॉज़ जो हम ब्रीथ कर रहे हैं, जो स्पोर्स आ रहे हैं, वो हमारी नोज में आ रहे हैं, और नोज में जब वो सेटल हो जाते हैं, वहीं से इन्फेक्शन शुरू होता है और उसके बाद धीरे धीरे स्प्रेड करता जाता है. और क्योंकि इट इज इन्वेजिव फंगस, इट इन्वेजेस आवर म्यूकोसा, देन बोन, इट रीचेस आवर साइनसेस, एंड देन आफ्टर साइनसेस इट इन्वेड्स आवर ऑर्बिट, एंड मे बी एट द सेम टाइम ब्रेन, और मे बी sequentially it may involve the brain. So it spreads very fast.
Please tell us about the early signs and symptoms.
देखिए, अर्ली साइंस एंड सिम्टम्स की बात करें तो इट रिमेन्स एसिम्प्टोमेटिक इन स्टेज 1 और 2. एक्चुअली राइनो ऑर्बिटल सेरेब्रल म्यूकोरमाइकोसिस की एक स्टेजिंग है प्रपोज्ड, जो कि स्टेज 1 में होता है नोज, स्टेज 2 में साइनस, स्टेज 3 में ऑर्बिट और स्टेज 4 में ब्रेन. इंपॉर्टेंट इज टू डिटेक्ट इट इन अर्ली स्टेज. एंड अनफॉर्चुनेटली अर्ली स्टेज में जब इसकी शुरुआत होती है तो सिम्टम्स ना के बराबर होते हैं. कुछ पेशेंट्स में स्टफी नोज की फीलिंग आती है कि नोज में स्टफीनेस आती है और ब्लॉक हो जाती है, जो आमतौर पर लोग सोचते हैं कि जुकाम है, नाक बंद हो गई होगी. हालांकि जब ये स्प्रेड होती है तो आंखों में जाकर, मैं एज ए आई स्पेशलिस्ट में बताना चाहूँ, जो आंखों में सिम्टम्स आते हैं बहुत अर्ली स्टेज में जो आते हैं, वो बहुत माइल्ड से लेके बहुत सीरियस हो सकते हैं अर्ली स्टेज में. क्योंकि अगर वो ऑर्बिटल एपेक्स को इन्वॉल्व करता है, यानी कि आंख के पीछे वाले हिस्से को, तो इट में सडनली गिव ब्लरिंग ऑफ विजन, इट में सडनली गिव कंप्लीट loss of vision by causing a central retinal artery occlusion. It may give blurring of vision by compressing our optic nerve. It may give pain also, and sometimes it may simply give congestion and chemosis, यानी कि आंखों में लाली हो सकती है और आंखों में थोड़ी सूजन आ सकती है. और जैसे जैसे स्प्रेड करता है, फिर हमारी आंखों में प्रोप्टोसिस, लिड एडिमा हो सकता है. और अगर जैसे मैंने पहले बताया, सेंट्रल रेटिनल आर्टरी ऑक्लूजन जब होगा अगर ब्लड वेसल्स इन्वॉल्व हो रही है, पर अगर नर्व्स इन्वॉल्व हो रही है, it may give neurological symptoms in the eye, जैसे double vision, paralysis of eye, development of squint. It may also give lid edema, जो कि बहुत सारे लोग टाई या सिंपल इन्फेक्शन मान के उसको चलते रहते हैं और एंटीबायोटिक शुरू कर देते हैं. इसमें हाई इंडेक्स ऑफ सस्पिशन बहुत जरूरी है. अदरवाइज म्यूकोरमाइकोसिस के सिम्टम्स अर्ली स्टेज में तो पता चलते ही नहीं है, इवन स्टेज 2 से स्टेज 3 तक भी मिस हो सकते हैं.
It's generally it comes from the they give oxygen to them. The nasal जो होगा, it comes through that. Suppose instead of the nasal tube we give a mask, will it reduce the thing?
It is otherwise also it can happen, क्योंकि जो spores है, spores are there, it's a ubiquitous, it's available, it's there everywhere. So why does it happen? First of all, yes, if we are using a nasal tube or even mask which is not sterilized or which is not sanitized, so it is possible that spores are there in the tube itself, and if there is a growth, fungal growth in the tube or anywhere from the oxygen cylinder or oxygen supply to the nose, yes, there will be more number of spores entering our nose and patient is more likely to get it. But the important question to understand here is that it is more the immunocompromised status of the patient which is giving
Yes,
this disease. Even now, if I'm breathing and you are breathing, we are probably inhaling some, a basic amount of spores, which our immune system is taking care. Now,
Yes.
why we have got this new epidemic or pandemic? Because patients are immunocompromised, as patients either diabetic or they are on because of steroids, their immune system is compromised. Lungs anyway are suffering because there is a low oxygen level. High flow oxygen definitely is giving more spores, pushing more spores to nose. Patients are hospitalized, and because of lack of infrastructure or whatever, our health infrastructure is overwhelmed. Patients are admitted in wards. If you see, many facilities are made in open where tents are there. Air which is available there is not so clean that availability of an opportunity for spores to enter our nose, lower immune system, then metabolic abnormality like metabolic acidosis and uncontrolled diabetes. So all these factors have uh, gathered together to give this new situation. It's not possible to avoid it by using mask in place of nasal tube. But yes, one important thing is that avoid using the same tube in all the patients, because oxygen is being given at home also, and because of shortage of tubes, people are reusing it. They are simply cleaning it with alcohol or something from outside, but the inner side of tube, which is
Yeah,
actually the
that's
source
right.
where fungus is there,
Yes, that's right.
using a new tube or maybe sterilizing it with the authentic way like ethylene oxide, a good way to reduce this problem.
ठीक है. I agree with you. So when it is the irreversible stage comes, when we can't do anything.
Sir, frankly speaking, if a patient reaches stage 3, the prognosis falls very rapidly, the prognosis of survival. And if it involves brain, then fatality rises very sharply. So, if we detect it at a stage 1 when it is in nose, or maximum at stage 2 when sinus is involved, a patient is still salvageable. If it involves orbit, then most patients will land up into evisceration or enucleation or exenteration, because this fungus is resistant to most of the medicines available. There are very few medical options available like amphotericin B, posaconazole. These are the medicines which are effective, but the basic nature of this fungus is very invasive. So once it is crosses sinus, then I fear that it may land patient is in problem, because other thing is those patients are already immunocompromised. Their natural defense system is very weak. So the paramount of importance is that we should detect it when it is confined to nose, or at the maximum when it is sinus.
Sir, what is the treatment for it?
As an ophthalmologist, we generally have to do examination and suggest that what can be done for the eye. Medical treatment involves IV antifungals like amphotericin B, is posaconazole, any other antifungal, whichever can kill this mucormycosis. Debridement is very important part if it is spreading very fast. Even nasal irrigation or sinus irrigation with amphotericin B is a way to reduce the fungal load, but whatever tissue is involved, we have to debride it. So surgical intervention is also a part of it. There is an option of giving intraconal amphotericin B also at a fixed concentration to kill the fungus, whatever has reached the orbital apex or into the orbit.
What investigation should be done, sir?
Sir, first of all, high index of suspicion is very important.
Agree.
Clinical examination, yes, it is very important. As ophthalmologist, generally by the time we realize that it has reached it is stage 3 already, imaging of paranasal sinuses and orbit is most important. This can do the job, but nowadays most patients who reach this stage, they have already undergone HRCT of their chest 2 to 3 times. To reduce the exposure of radiation, I am advising MRI to the patients who contrast MRI. It is very much diagnostic, and it can suggest what staging we are dealing with.
Sir, generally we see the COVID patient, they are being given dexamethasone, and we say dexamethasone is life-saving in these type of cases. They may increase the chances of mucormycosis. What do you think? We have to make a balance, or it should be given early stages, late stages? What stages should be given?
Sir, I believe physicians, those who are dealing with moderate to severe COVID, they don't need to change their protocol first of all, because COVID is killing people faster than the other, the incidence of mucormycosis is still less than the rate of death because of the fear of cytokine storm. The threshold of using steroid has gone drastically down, and it may be rightly so, because there are patients who are going into cytokine storm phase on a day 2 or day 3 sometimes. So I believe it's very difficult to titrate, but yes, the priority has to be set in by the physician, because they are the people who are facing it from at the front. Steroids, no doubt, has a life-saving role, but I think we have to substantiate our use of steroid by timely, by some supported by some investigation. And to our surprise, there are patients who are non-diabetic, even in 20s or 30s. After giving steroids, their blood sugar shot up very fast, 400, 500, and that is easily missed. And by the time it is detected, I think it's too late. If possible to avoid steroid, it is always better. If it is to be given, give it, because it is life-saving.
थैंक यू सर डॉक्टर गुप्ता जी। और डॉक्टर साहब, आपकी जो ऑप्थेल्मोलॉजी की आपने हमें इतना ज्ञान दिया है, उसके बहुत थैंक्स सर। और हम ख्याल रखेंगे आगे से कि म्यूकोरमाइकोसिस नहीं हो।
It was very enlightening talk. I thank Dr. Shridhar for putting up very straight questions, and definitely I would like to thank Dr. Rakesh Gupta for answering them to the best. I thank you, both of you.